So we're going to talk to you a little bit today about the Education Summit that focused on education and implementation. And for those of you that are interested, there are a series of workshops that happen throughout the conference that you may want to follow up on to hear more information and to provide your input. So in terms of conflicts of interest, Adam and I don't have any financial conflicts of interest. Both of us have grant funding, but none of it is from industry. And we do have some intellectual conflicts of interest. We work with AHA, ILCOR, Heart and Stroke Foundation of Canada, and we are obviously conflicted in the way that we think, but it's not because of money. So what's the summit about? So the Education Summit brought together over 60 North American experts in resuscitation education, simulation education, and educators to think about a process. We took people through this for about a year, slightly more, I think, spent thousands of hours, literally thousands of hours of their work, reviewed all the literature in education and resuscitation and implementation to try to come up with something that can help you on the front line. Adam and I are up here to represent all of those 60 people. Some of that leadership group is actually here today. So we've got Vinay Nadkarni, Audrey Bluer, Betsy Hunt, and Beth Mancini, who are all here amongst others. And there's other people that were involved in the process. And so far here, I've seen Dana Niles, Costas, and I believe Ryan Shercliffe as well. Really, we're up here representing their work, and we don't want to be, this really isn't just us. So how did this work? We looked at the evidence, we searched for this, we got information specialists to help us find all the literature that's out there and tried to think and say, how do we apply what we know about education to resuscitation education? And think about how are we going to move ourselves forward. There's a couple of things that we want you to kind of think about. You've seen this slide before today already. Medical science, educational efficiency, local implementation. We focused really on the educational efficiency and local implementation. We do believe educational or medical science needs work, it needs research, we need to move forward. But in all reality, we don't think there's going to be a magical bullet there in the next 5 or 10 years. The only way that CPR outcomes improve is if we improve the educational efficiency and the local implementation. So there's a couple of things that guided us in thinking about this. There's a few assumptions. Assumption number one is that we all think that everybody here wants to help get better. Assumption two, we know that cardiac arrest outcomes are not as good as they could be. We train millions of people. So for those of you that don't know, American Heart Association, the last number I heard, but I think it was getting closer to 20 million, was about 17 or 18 million people trained every year. Yet we know that what is taught doesn't get implemented and put into practice. And if we want to do that, we're going to have to start to think differently. We can't just keep thinking about the same way of doing things and the courses that we have. So that's our guiding assumptions for where we're going. We thought we'd actually try to make this a little bit more relevant. That scientific statement will hopefully come out in publication over the next 3 months or so. We're not giving you everything from that, but we're representing our views and interpretations. And we thought we'd try to make it most practical for you guys by actually doing this in an interview format and discussing things that might be most relevant to you. So I'm going to start off and ask Adam a question and have Adam think about something. Adam, people talk about contextualized learning, and I know you've heard about this and thought about this. A lot of people in this room might have done that as well. So thinking about how can I make this more relevant to everybody's individual practice? How might we allow for that within the confines of courses that might be American Red Cross, American Heart Association, Heart and Stroke Foundation of Canada? How can we actually do that?
So good question. Interesting question, Farhan. So if we think a little bit about the example of virtual reality, and let's say that we're trying to train to become a go-kart racer. So there's 2 ways potentially that you could train. The first way is you could play a video game, perhaps virtual reality, and get used to the track, get used to making the turns, get used to the speed. Here's another way. Maybe you immerse yourself in an actual track. Maybe it's not the actual track that you'll be racing on, but you get to sit in a car, train on a track, feel the vibration of the wheel underneath your hands. The question is which of these training environments is most relevant? Which is going to lead to the best performance down the road? And so if we extrapolate that to resuscitation, we can ask the same question. What elements of realism are important, and how do we adjust the environment to optimize learning outcomes. So we're going to touch on three things. The first one is the notion of functional task alignment. Second, contextualized team training. And then lastly, the importance of relevance of the training environment that we provide. So in our review, we asked the question, does high fidelity simulation improve learning outcomes in comparison to low fidelity simulation? The answer is yes, it does, but marginally. But perhaps we're thinking about it the wrong way. What if we were to adjust our thinking and ask the question, how can we target the functionality of our trainers to the needs of our training? So if we take CPR for an example, all of us train here to improve our CPR skills. If you want to train an in-hospital healthcare provider to provide adequate CPR to a depth of greater than 2 inches or 2 to 2.4 inches, wouldn't it make sense that you're going to select a trainer that allows the provider to compress to at least 2 inches? Ideally, beyond 2.4 inches so that they can demonstrate the ability to titrate compressions to that tight range, right? Alternatively, if you're training, as we've heard this morning, to train lay providers, children, folks in the community to train, maybe the goal is not to train them to perform excellent CPR, but just to encourage them to do CPR, period. I would argue that then it's less important to use these sorts of trainers that allow you to compress to 2 to 2.4 inches, but rather just to provide a trainer, period, so that they can practice. And so let's think about functional task alignment, aligning the needs of our training to the functionality of our training devices. So what about team training? You can see here in a NASCAR team, each person has a specific role. Their task is to get the wheels on and off as quickly as possible. When they train in their role. So my question is why are we not necessarily doing that when we're running ACLS and PALS courses? Right? So often, I'll run a course and I have 5 physicians in the room managing a mega code case. How often would that happen in real life? With no nurses, right? Not that often. So it really doesn't make much sense that we're training our providers in this way, which is an environment that they'd never actually be in real life. And you can imagine that the skills wouldn't necessarily translate over because we're not dedicating enough attention to creating an environment which matches that they would experience in real life. Similarly, why would we expect, say, a nurse candidate in a PALS course to be assessed as a team leader at the end of the course when he or she would never be expected to do that in real life? Like, why are we spending time doing those sorts of assessments? So if I were to push it one step further, the issue of relevance relates to the training environment as well. So in the ideal world, if we're able to create an environment where all the resources in our training environment are the same size, the same location, the same distance from the patient, that would then potentially lead to improved performance of our providers, right? But of course, it's hard to create those environments for training. So then the question is how do we do that? How do we create realistic environments to allow our learners to train in these environments and then translate their learning into real life? And so I think we need to rethink the way that we deliver education, one of which is perhaps we can rethink about how we deliver education and pushing more of the education to the workplace-based environment where there's opportunities for people to learn and be assessed on shift or in the hospital, for example, as opposed to having to come every year or two to complete their courses. And so let's think about these concepts as we're designing our training opportunities, and with that, I think we'll be able to improve learning.
Excellent. That's great, Adam. Thank you. I should have noted that your conflict of interest must be that you've now learned to speak American. You've gone to inches and NASCAR instead of centimeters and hockey. I think, congratulations. Well done. You're now bilingual. Moving on a little bit, thinking about feedback debriefing. Let's think about a scenario where many in this room might be PALS instructors, ACLS instructors, some situation where you're dealing with a team and you've come through watching that team and really that performance was horrible.
Right.
The leadership was terrible, the instructions were not clear, the time to defibrillation was long, the quality of CPR was poor. How do you try to think about improving people using feedback and debriefing, and what are we doing wrong and how do we move that forward?
So I think the good thing is that all of us in this room have been the recipients of feedback, right? How many of you, show of hands, have received feedback that was delivered poorly? Right, over half the room.
By you last night. No.
So there you go. So one of the things, if we think about debriefing, one of the core notions that makes debriefing effective is if you're able to create an environment where your learners feel psychologically safe. Because remember, as your learners are participating in the debriefing, you're asking them to reflect collectively on their performance, bring up issues that occurred, and then work together to solve those problems. And in doing so, they're really putting their professional identities at risk, right? You're asking them to show vulnerability, to come up with issues that occurred. And so as facilitators, as educators, it's really important for us to be able to pre-brief for success, spend time creating a psychologically safe learning environment, and then nurturing that environment throughout the educational process or learning process. The second thing that we found is providing debriefing in a structured format helps to improve learning outcomes. And so that means the use of debriefing tools or scripts such as this one, which was developed back in 2010, included in the instructor materials, and then is carried through to 2015, a debriefing tool that supports the implementation of the GAST model of debriefing in ACLS and PALS courses, for example. And we found that facilitators who use this tool to support their debriefing, asking questions in the ways that are phrased on the tool, that helps to promote more discussion, more reflective learning, and ultimately improve performance, both behavioral and clinical down the line. So there are other tools available. For example, this one, a tool that our research group developed called the Pearls Healthcare tool that helps you to implement debriefing in a blended fashion, including learner self-assessment, a method of debriefing called advocacy inquiry, as well as directed feedback. And so this tool is actually available on an open access website called debrieftolearn.org. And on the back of that tool, you can identify what performance domains you want to discuss, and then specific questions and sample phrases for the 3 approaches to facilitating discussion that I just highlighted. The last thing that I think is really important to remember about debriefing is that data is critical. And so in this study conducted by Heather Wolf and the team at CHOP, they proved that the implementation of a clinical debriefing program that includes real quantitative data collected by a defibrillator saves lives. In fact, pre versus post, in post implementation of this debriefing program, they saw a nearly 2-fold increase in survival to discharge and intact neurological survival from cardiac arrest. So I would say there's probably no drug that we know of that can improve survival as much as clinical debriefing with data can. And so debriefing saves lives, but furthermore, debriefing with data saves lives. So if we look at our sources of data, it can be video review, it can be our defibrillators, perhaps even things like digital tablet devices that allow us to track when epinephrine was given, et cetera, and that can be displayed during the debriefing to help to improve performance down the line.
Excellent. Thanks. So, Yoda, thinking about mastery learning, let's suppose one of your faculty comes back from a meeting just like this. Says, I've heard a lot about mastery learning and how that actually improves outcomes. Can you tell me a little bit more about that? What does that mean? How do I get people to actually do that? And you know what? I'm stuck in the confines of a course. How do I actually think about getting people to perform at their best at the end of that course?
Right. So it's a great question because I think we're doing great training right now, but unfortunately it's not really translating into improved long-term sustained performance, right? And so we need to rethink about the way that we're structuring our educational offerings. And mastery learning is sort of tried and proven in the educational field as an instructional design feature that really translates to improved performance. And so for mastery learning, there are a few key things. Number one, your learners come in and they receive a baseline assessment. Number two, they have opportunity for repetitive and deliberate practice, and they are to continue to practice until they demonstrate that they're able to achieve a preset standard of competency. And they're not allowed to proceed to the next module or to the next task until they demonstrate that, right? So assessment is part of the learning. We're not doing that enough right now. The key to make this ultra effective is to ensure that the behaviors that we pick for mastery learning are directly linked to patient outcomes. So I'll give you an example. We know that if you defibrillate a patient early, in cardiac arrest with a shock rhythm, the earlier you defibrillate them, the greater the likelihood of survival. In fact, with every subsequent minute that passes, their survival rate drops. So what if we were to train our teams in a simulation-based fashion with tiny, short 1 or 2 minute simulations where their primary task is to demonstrate early defibrillation. And they are asked to repeat that simulation, the 1 minute simulation, over and over and over again until they demonstrate competency. Right? So they have to demonstrate that they can defibrillate within the first minute. You could see how within the traditional time that it would take for us to run one simulation and one debriefing, that team may have 5, 10, 15 maybe opportunities to repeat that scenario over and over again to demonstrate competency. So let's think a little bit of how we can incorporate mastery learning into our courses and target to relevant outcomes. Secondly is this concept of overlearning. So if we take the skill of CPR, we know from the evidence that the skill is acquired, and then shortly after, whether it's 3 months or 6 months, there starts to be skill decay. This is no secret, right? And some learners, they actually never are able to demonstrate or achieve competencies. Others may just meet that target and then slowly decay afterwards. But what if we were to apply the concept of overlearning and train them above their target of competency? Let's say the target competency is 80% compliance with AHA guidelines for CPR depth. What if we were to train them to 95% compliance for AHA guidelines for CPR depth? You can see then that as they decay, they'll start to come to low competency a little bit later. And then if we were to lay on another concept called spaced learning, so instead of training our providers every year or 2 years, we ask them to train every 3 months, as with the RQI program, or perhaps even more frequently. Spaced learning in combination with overlearning would then make the curve look like this. And so then you have a provider or group of providers that very rarely ever fall below the line of competency because they are practicing frequently, and at their initial bolus, they were overtrained, so to speak, to achieve competency.
And any thoughts on how we might actually do that practically within courses or within the confines of what we're faced with in terms of teaching?
Right. I mean, I think even at this conference alone, we've seen many good examples of how digital interfaces could help. Right. And so with the example this morning, or actually yesterday I was in a workshop, I think Audrey presented some really good work on video-assisted learning, and they developed an app where people could practice CPR at home. Why can we not develop apps that allow people to practice at home, but also collect data on their performance at home, and then have that data sent to our training centers so that every single time they practice, it can be logged in their own student profile. And so when they come back a couple years later, maybe there is mandated in-person training, they can say, listen, I practiced 150 times over the past 2 years, and each time I was able to demonstrate competency. So there are ways for us to structure training that don't necessarily require the learner to come to a training center.
Okay, great. Thanks, Adam.
So Farhan, I think it's time that we sort of switch the hot seat and
Sure.
put you in the hot seat for a bit. So let's talk a little bit about faculty development. So I've talked about feedback, we've talked about debriefing, mastery learning, contextual learning. Some of these concepts may not be familiar to our educators and instructors. So maybe if you can share some thoughts related to faculty development. How do we best train our educators to improve outcomes of our learners?
So I think this is actually a really, really important challenge, Adam. When you think about how we develop our courses and how we develop materials, we do a really great job of developing materials. We have people on the end, in most instances, that are motivated to try to do their best. I think there's a gap in how we train our faculty and how we support them. And I'm not speaking for everyone, but I think that if you were to look across the way, sometimes that gap is the important one that doesn't get in what we intend in our courses down to the people that need it. And so I think that what we need is actually a bit of a culture change. And by the culture change, what I mean by that is our faculty need to get in their minds that ultimately what they care about is not that this person passed a test here, is that they're happy that this individual will be able to provide resuscitative care to their mother, their father, their sister, their brother, and be able to do that well, and when they can do it in a crisis situation. And that's the target that we want them to hold to. And I think there's another concept where we think about things where we're afraid of feedback, we're afraid of growth a little bit, And many of us have what I would call, what Carol Dweck, as a psychologist in California, called a fixed mindset. When something challenges our intelligence, we push it away because it's threatening to us. What we actually need is more of a growth mindset. And that growth mindset has to be, I'm doing this really well, but I want to get better. And the best example of that was this morning when you heard the group from Seattle, Chicago, Denmark talking. These are people that are doing a fantastic job. And what they're thinking about is not, I'm doing a fantastic job and any information coming back is criticism. What they're saying is, doing a great job, how do I get even better? And I think that's a lot of the reason why people in this room are here, but I think we need to find a way to change the culture of everybody that's delivering these courses so that they do that as well. And to be able to explain things in that safe learning environment that the learners feel that that's the important thing as well. It's not a card mill, it's about getting yourself to a level that you can deliver this amount of care. So the way that I think about faculty development is twofold. We've always thought about it as courses, training them, doing a little workshop, giving them material. That's well and good, but I think you need to think about faculty development from two lenses. One is that formal faculty development, which might be a workshop, a webinar, give them content material, help them learn how to do debriefing, help them learn how to do assessment, figure out how they can incorporate a CPR feedback device into practice. But the reality of things, and the most valuable thing that I think you'll get out of here, is not listening to people talk in plenaries, but is actually to talk to each other. And to start to develop informal mechanisms of faculty development and developing that community of practice. More of what we do happens in that realm for all of our real world lives than any other point. And if people are interested in reading more about this, there's a best evidence medical education review by Yvonne Steinert and colleagues that talk about the formal and informal faculty development and how you can capitalize on that informal to make things better. And I think what we need to do to introduce that is to model that behavior. So we have to be out there as leaders saying, I did this. How did I do? Adam, come with me for this one and give me feedback. If we start to model that behavior, it becomes something that becomes part of our routine. And what you want to do is just start small. Just start doing something. If you start doing something, it starts to build and it becomes a culture. And eventually culture goes into habit. And I think that's the best thing that happens in some of our high-end resuscitative communities.
Right, so I just want to highlight the example that you gave of peer coaching and the importance of peer feedback. And so, you have this opportunity within your courses to give each other feedback. You're both, let's say, ACLS instructors. Why can you not give each other feedback and both over time improve your skills? And the way to do that, I think, is for all of you who are leaders within your programs, demonstrate some vulnerability. Work with that junior instructor and seek feedback from that junior person. That way, when it comes time for them to receive feedback from you, they'll be more willing because you have already set the example by seeking it. Right. And through that, I think that helps to build a community of practice, right?
And it's that creation of a safe environment that really is critical, and getting everybody to think about growth rather than threat of external assessment.
Right, great. So last topic, I think, comes with the issue of implementation. Along the lines of the formula for survival, let's say that you're a training center director, you're an emergency doctor as well, you walk through the emergency, and then 6 or 7 of the learners who had just taken a course with you are managing a patient in cardiac arrest, and they are clearly struggling. CPR quality is poor, there are prolonged pauses, and unfortunately the patient has a poor outcome. So tell me, what additional things can we do on the ground in our workplace to help to ensure that guidelines are implemented?
So what you're asking me to do is summarize thousands of hours of research and work that people have done.
Yeah, you have about 3 minutes.
In 3 minutes, yeah. Okay, so in thinking about it, I think there's 3 key things. First one is thinking about design thinking. And what I mean by that is, how can you structure the environment so the right thing to do is the easiest thing to do? So in the hospital setting, they tripled the rate of hand washing by putting a sink outside a patient's room. You make that easy to do, the right thing becomes there, and people do it. CPR feedback devices are hard to implement in practice. You've got to figure out where you put your feedback device such that the person doing compressions or the leader or coach of the person that's doing the compressions can actually see that. And I think that's a critical piece. The other big piece for me, and you've heard a lot about this morning and in some of the workshops as well, is performance measurement. Right? You can't improve what you don't measure. It's kind of like thinking to drive a car without a speedometer, trying to fly a plane without an altimeter. You need to get that feedback loop closed so that people can improve. It's the same principle in education where you use feedback and debriefing, the same thing for that system. And to pay attention to that is what actually works. That debriefing study that you showed by Heather Wolf really was an example of closing a feedback loop, because they took that information and then debriefed it at a point in time so that everybody could improve, not just the single individuals that were responsible for that particular code. And I think that's a critical piece. In an ideal world, and there's pros and cons of this, but to start to think about how public reporting might actually help us to improve, and it's been shown to do that in other domains. We might not be ready for that yet this day, but it's something that we should be trying to push the agenda for, to say, if we were putting our outcomes there and we know there's a 6-fold increase in cardiac arrest survivals depending on where it happens, then I think knowing that, we'll want to try to improve there and put that out for our public members. The last thing that I really wanted to mention here is that change is difficult. Well, maybe it isn't. Maybe it's just hard north of the border. But I think that change is actually something that, it's a challenge. And the expression that I've heard is that the only person that wants change is a baby with a wet diaper. And what we have to think about is how to engage people in that change process and move things forward. This is Beckhart's change equation. And for those of you that haven't seen it, it's a great way to think about things that frames everything that you do, and including many of the changes you heard about at the plenary this morning. You've got to start off with what's the dissatisfaction? What's the problem with where you are now? Why am I changing this? And if you want to hear a great TED Talk, listen to Simon Sinek that talks about start with why. Explain the why to people, and they'll accept change easier. Create the vision for where you want to go, and then create concrete first steps. Build those first steps and start doing that. When all of that, actually this shouldn't be an equals to, this should be greater than. When that exceeds the resistance to change is when change can actually happen.
Right. And so if we just finish up here by looking back at the formula for survival, if we target these two areas here, local implementation with the 3 elements that Farhan just described, and education with some of the elements that I described, I think we could start to move survival rates up from what they are right now to more favorable survival rates. And so if we look to the future, I think I would ask you sort of to take away 3 things. That if we challenge ourselves to enhance instructional design of our educational offerings, that will improve learning, and that in turn will improve outcomes. If we focus in on our faculty and train up great faculty, ensure that they have lifelong learning opportunities, that too will translate to improved outcomes. And lastly, let's think a little bit about what we can do on the ground, in the hospitals and in the community to ensure the implementation piece follows through. So we'd like to extend a thanks to the American Heart Association for supporting this work, specifically Brian, Joe, Eileen, Noel, and Amber, who were key and critical in supporting us to achieve and to complete the simulation, the Education Summit. And so what I hope we've done is sort of plant a seed, give you a few things to think about, things that potentially you can alter or tinker with and play with at your own institution. And hopefully these changes will lead to enhanced outcomes in the future. Thank you.